Good morning, everybody. Thank you so much for being here. And Shobha, for organizing this podcast session. Um, Before I start, I would like to first acknowledge my ancestors, my elders, and my teachers for whom I would not be here today. I don't have anything to disclose. Um, why am I standing here today and talking to you about this? I think it's important that you understand where I come from in order for you to listen to where I'm going. I have my medical training from India, and it's probably was the one female physician before ARVs, working at an NGO run by Dr. Suniti Solomon, and I was the only female physician, and we had the first Indian women's clinic. And in our clinic, we used to see a lot of young women who would come pregnant, and they were just diagnosed with HIV. Or we would see women who were bringing in their husbands to take care of their husband's infections. And then we screened the women, they had HIV, and a lot of them had precancerous lesions. So that was where it all started. And working in a resource limited setting with difficulty to triage people from the time you find out what they have to where they go was something that I've seen a lot. And then that led me to prevention. So why do we even have to wait till somebody is infected? How can we prevent that? So that's when I went to the States. I went to the University of California, Berkeley, got my master's in public health, and I got a PhD in epidemiology. So I'm very proud of my training. It was rigorous, painful, but yes, got a lot of gray hair, but I learned a lot. And then I moved on to actually applying all this awesome things that we learn in the West back in our community. It's not enough for us to just leave and learn, but it's also important for us to bring it back into our community. So we've been working in India for almost 25 years now, but we also have done work in AE and down into the Republic, Ethiopia, Nigeria, South Africa, Colombia. And of course, in my own backyard, the United States, it's not like we don't have disparities. We don't have inequities. We have places, believe it or not, which doesn't have running water or toilets in the United States. So there is a lot that we can learn from each other, and that's what I do. And I'm very focused on equity. So a lot of my work, although I'm trained as an epidemiologist, I use a lot of mixed methods approaches. So most of the work has participated in research methods. I'm not going to go over a lot of the statistics, you all have done a lot, but I will tell you what our organization is doing. What were some of the challenges we faced with setting up the screening program, and where do we go from here? Just to understand the new infections that are happening globally, because I have a very close understanding of the US and India, I wanted to compare and show you the new cases in the United States is about 6.3 per 100,000. It's about 70 per 100,000 in India. At the same time, when we think about mortality, it's about 2.2 per 100,000 in the United States, but it's 11.2 per 100,000 in India. That means there's one more dying of cervical cancer every 2 minutes. So we won't see the elimination strategy to focus on 90%, 70%, 90%, just won't go over it. But I want you to take a look at this. This was a paper that came out a while ago, which reported 16 per 100,000 as the rate for a 30-year-old Indian woman. She has the risk of dying of 0.7% from cervical cancer before she turns 17 with no competing causes. On the other hand, her risk of dying from pregnancy is about 0.6%, which means a 30-year-old woman has more risk of dying due to cervical cancer than dying during pregnancy. But most of our resources in India are focused on maternal child. So cervical cancer accounts for like 0.4% of all cancers. It's one of the leading causes of death among women. 1 in 4 cancer deaths happen in India. We have about 289 million susceptible women, and our current rate for screening is 1.9%. Our current vaccination rate is less than 1%. And 2/3 of these women will die. They leave behind young children and broken families. The government of India did roll out a chronic disease prevention program in 2010. It's a program. It's a program. But now the question is it running? And that's where I think the most of our discussion just to be. So in order for us to build a robust cancer prevention program, you need a lot of different things. We need that needs assessment. We have to have that education in America, which we will talk to so well about. Capacity building at all levels, which Dr. Priya talked about. Screening, which I will told you for some minutes. And continuous improvement, quality control, and sustainability. We can all start fantastic programs. What's important is sustaining it. How are we going to continue to sustain these programs? So Public Health Research Institute of India, we are located in southern India in a place called Mysore. I can't say we are a hospital, I can't say we are a clinic, we are a mishmash of everything. So sometimes we do have an identity crisis when we go and talk to people to say we are PHRI, because they don't know which box to put us into. But we do everything. We do research. Our research informs our service, and that services inform the questions we ask in our research. So our mission is research and service, continuous learning. It is an NGO. We are focused on women's health across lifespan, and we want to impact policy in India and world. So our program started in 2008. The way we started it was we worked with an NGO called Prevention International to solve the cancer. It is an organization based in California. They sent a few doctors to us who came to train our doctors on using visual inspection with acetic acid. So they would come back every 6 months and train us, and then we would roll out the program in the community, and then whatever additional training we need, we would come back to it every 6 months. So we just started it, and then we kind of took it into the community. Now that we have trained clinicians, we needed to prepare the community. So we started to work on preparing material for the community. So what we did was we worked with some local artists. We set up, developed all of the IC material we needed. We prepared the women in the community who were going to be our spokespeople in the community. And then while we were doing this, we were simultaneously setting up a train the trainers program in 2010 so that we could have a wide reach. And then we started the screening program. Since then, we have come a long way. If we kind of go through the timeline, we have done primary prevention, secondary prevention. We have recently continued on with tertiary prevention. We have services which integrate research. So this has a few visuals where I wanted to show you. These are women from the villages who love to talk. We had no other criteria except women should love to talk. And we got them to come, and we trained them in talking about cervical cancer. And we didn't use didactic lectures. I hate sitting and having somebody talk down to me. I don't want to do that with you all, but I'm sharing what we did. Essentially, we use a lot of interactive play and games and humor. A lot of our work involves humor and talking. So we got these women from the villages, and then we trained them in using the material that we had developed. If you look on the right side, it shows a visual of how a woman's body changes. Essentially, what we did was anything that was in words, we converted into visuals. Yeah. And then we got those visuals into a flip book that we got the women to use, so that when they go back into their communities, they will have something to talk to their neighbors about. And you'll notice that there are two views sitting there. We cannot do any of the work that we are doing without the support of men. Men are very important. So all our programs, they were implemented at every level. So that was in 2009 with our first VIE camp. And as you can see, I had a lot more black hair then. Life changes. As an NGO, we are constantly running out of resources. And as I said, men at every level matter. So this was they were like the directors of the hospitals who came out and supported the programs that we were rolling out in the community. While we did that, we were also creating awareness and training the community health workers. These are ASHAs. ASHAs are accredited social health advocates. We have one ASHA per 1,000 population in the community. So we worked with all the ASHAs to come and learn how to talk about cervical cancer. At the same time, we were also working with general practitioners, people who are in the village, close by to the villages. We don't have specialists in villages, close by to the villages. All the fancy doctors are up in the city. So you have to work with what you have. And most of the general practitioners, they're the ones who are practicing in the periphery, so we work with them. And then, when we talk about mobile clinics, those are not the fancy SUV guys. We don't have that. We just find the vehicle that can fit all the luggage that we can put in. We can take it right into the villages. So we're offloading everything from a garbage bin to a garbage bag to everything. We take it with us into the villages and we set up shop wherever we give permission. Most times it's in a community health center or in the corridor of a school with one classroom and they would allow us to use. Like I said, we carried everything with us, including the examination tables. We have designed portable examination tables. We take them with us into the villages. And then we set it up in a classroom. We have all the tables. And then as the women lie down to get their screening done, simultaneously the doctors and others who are getting trained, they are watching, learning. And while the women are moved off the tables, the providers continue to have continuous education. What did you learn? What are the pieces that you didn't understand? And of course, everybody says it's so difficult to teach biopsy or leaves. We're teaching leaves right here in the village on a piece of meat. That's a piece of mutton, which we got from the village store. And we were teaching the doctors how to do leaves before they can go and touch them in an edible leaves later on in their own practice. So this cervical cancer screening Cascade, it starts all the way from awareness to screening, diagnosis, treatment, and follow-up. Now, where are we losing women? We're all talking about loss to follow-up, right? Where are we losing these women? Well, we're losing women at every step. It's happening even when services exist. And we have a lot of behavioral and psychosocial cares. The first step where we lose the major number of women is from screening to triage. This is the initiation crowd with only 2% uptake, which means we are losing 98% of the women. 98%. And why? What is deterring these women from coming into screening? Well, the first biggest challenge is no awareness in autonomy. There is this lack of perceived risk. Oh, it's not going to happen to me. It's somebody else's problem. Or they don't think it's important. They don't realize the benefits of screening. And many times, there are gatekeepers. I have to ask my husband before I can come into screening. Or I have to find out from my mother-in-law if I'm allowed to go and screen. So we have those gatekeepers who are also very important in order for us to get within screening. And of course, we have social cultural stigma. This fear of pelvic exams, fear about women who have left their slippers and underwear at the table and run away. There is acute fear of pelvic exams. And of course, there is this whole issue of lack of privacy and social stigma about cancer. The minute you say pre-cancer, they forget. Like Venus said, it's not what we say, it's what they hear. They're not hearing pre-cancer, they just hear the word cancer, and that's a death sentence. So the consequence of this is we are losing about 98% of the eligible women even before the process starts. So when we are in the community, like I said, we've developed all this IEC material, and we have our women, the trusted messengers in our villages, who actually speak to the other women, bring them into our camps, and then our own team members reiterate this information again. We do that in the room first, and then when they come into the room, we repeat. We need to understand what they have understood, what is going to be done to them. We find out from that, from their own mouth, before we move them into the clinical exam. We use a lot of education and awareness. Anything that we do in the community always starts with education and awareness, and we have done it for a range of different things, all the way from maternal child health to chronic diseases. We use peer education, interactive presentations, flip charts, informative videos, and a lot of role play. I want to share with you one of the studies. Like I said, it's the research which informs service, and service which informs research. One of my awesome colleagues, Prajakta, she was my postdoc, and she came and did her first project, which was essentially a community-based participatory research. It's a 4-hours project to identify perceived barriers to cervical cancer screening for women residing in rural and tribal communities. What did we find? Essentially, photo voice is where you give women or the participants cameras into their own hands and tell them to tell us their story. We are not telling the story. They are telling us what is their story. So when we asked these women what are the barriers, we found an overarching theme of lack of knowledge, lack of family support. Religious beliefs played a huge role, and fear and stigma. And we identified action steps for each of these 4 things. These are some of the visuals where the themes came out. I'm not going to read the quotes. This was one of the women who showed a pomegranate, and he said, unless you open it, you don't know what's going on inside. Another theme about permission was, this is a woman taking a picture from the gate and saying, I cannot go out without the permission of my husband and my extended family. This was another visual on beliefs, where she said, my family will go and put tons of money into a temple, but we may not spend that money on spraying. And of course, the stigma of death and cancer. This was a woman who, when she hears the word cancer, she thinks about cemeteries. So we had to identify action steps for each one. So what we did, we worked with existing networks. We developed material which can reach all the gatekeepers. We are still trying to figure out how religious players will play to this narrative and survive the stories. So we have used this to then build on our cervical cancer screening program of not doing VIA and move on to HPV DNA testing. So these are again some of the narratives and awareness programs. Here is where when we are explaining the woman how she has to go and collect the vaginal swab, and then she brings it back to us, and then we bring all of it back into our clinic, and then we do our cervical cancer screening. So essentially, we are using existing networks. We switch from VIA to HPV DNA, and self-detection makes a huge difference. And we use mobile clinics with reference systems. We have it all set up. I'm not going to go through all this now. Just wanted to show you, we see a lot of different genotypes, and many of them are vaccine preventable. So we do need a vaccine even for women who are undergoing screening. They will benefit from vaccinations. The second part where we lose a lot of women is this referral track. From the time you find that they're HPV positive to when we have to take them in consultation. Again, here we have systemic barriers like cost, time, logistics, and first infrastructure. So this could lead to more cancers, as Malra was very quickly. One of the biggest challenges we had, which one of my colleagues presented, was the attrition was lack of family support. You see how family support keeps coming back. And this is one visual I want you all to take a good look at. This is a visual like what Cheryl was saying. It's very, very specific to communities. you can see that the houses are very well constructed on the right side, and they're not so well constructed on the left side. And that path also divides the socioeconomic class of the community. So if you put your clinic on the right side, the lower socioeconomic class people cannot come. If you put your clinic on the left side, the higher socioeconomic class will be coming. So you have to understand the dynamics of the community. This is a visual of a primary care center, and that's the best we can have. So when the government says we have a lot of equipment, sure, they do have equipment, but they've never been taught how to use a sterilizer. It's there, but it's never been used. So there's also the training that we need to think about. So we've done a lot of work. We've reached over 100,000 people. I'm going to skip how to build a cervical cancer prevention program. Just solutions briefly. Yes, using high-performance FPV-DNA works, has better performance. Positioning it by self-sampling helps, and we can scale this up. For the second referral gap, screen and treat or screen triage and treat helps. And again, we have the technology for it. And here, the government has insurance programs that will help us in getting more women to do this. And what we are doing in Mysore is we have a hub and spoke model where we are able to go into the periphery and get women to come into our central clinics where we actually offer all of this tertiary care services. Okay? So, the Mysore Consortium, I wish I could talk to you all about it, but I'm going to leave it. I want to finish with this. We are all talking about screening, but here is a woman who was diagnosed with cervical cancer, and when we were talking to her, she took this picture and she said, "This picture shows me hugging my goats. I used to get emotionally depressed during cancer treatment. I needed to hug somebody and cry, but I had no one. These two were my companions, and unfortunately I had to sell them to raise money for my treatment." Okay? So these are the survivor stories, and we share it with the gatekeepers and policy makers. And this is the challenge that we're all going to have in our communities. Yeah, the last picture. I'm going to skip all this. We raised the money to buy her the goats, buy her the fodder for a whole 1 year, because everybody needs somebody to hug. Everybody. And that's what mattered to us. That the people we touch make a difference. So I'll stop.